Unfortunately, this is the less understood and at times overdiagnosed condition, especially in the Western world. So if we go through the literature, there are so many papers and so many synonyms for this single condition, almost 34 synonyms. The commonly we know it as Sudeck's atrophy, reflex sympathetic dystrophy, and shoulder hand syndrome, which is very commonly seen after distal radius fracture, especially the conservative treatment. In 16th century, it was first reported by Ambrose Paré, later on by Percival Pott, then Michel, and in early 20th century by Sudeck, who described the features like pain, swelling, atrophy, etc. And in 1991, the pain conference termed it as chronic complex regional pain syndrome. So by definition, CRPS is a multi-symptom, multi-system syndrome, usually affecting one digit or one or more extremities, but may affect virtually any part of the body. So it is a debilitating, painful condition in a limb with distal predominance of symptoms, and pain is the leading symptom, which exceeds both in magnitude as well as duration. There is significant impairment of the sensory, motor, and autonomic function, with variable progression over time and associated with psychological distress. A paper from Netherlands reported incidence of 26 patients per 10,000 patients across all ages. The peak is between 50 to 70 years, and the female to male ratio is about 3 to 5:1. And the upper limb involvement is more common than the lower limb involvement. Usually there is preceding event like fracture, surgery, minor trauma, or nerve injury or compression neuropathy. But no relation between severity of trauma and presentation was found. CRPS type 1, that is associated with trauma or minor injury, is more common than that is associated with neural injury. So any inciting event or trivial injury to the limb, injury to the peripheral nerve, whether it may be a distal end radius fracture, tight cast, or a wrongly given cast, or operated distal end radius, whether it may be a fixator or a plate, that can lead to CRPS and presents as exaggerated inflammation, leading to swelling, changes in color of the skin, increased skin temperature, pain, hyperalgesia, increased sweating or reduced sweating, tropic changes due to cytokines, impaired motor function due to peripheral inflammation, and increased levels of tumor necrosis factors. The pathophysiology is not very well understood for many years, but there is altered cutaneous innervation, altered peripheral sensation, altered central sensitization, and afferent sympathetically median pain pathway, and altered processing of cortical reorganization because of inflammatory mediators. So there is increased tonic activity in myelinated mechanoreceptors afferent, leading to mechanical hyperalgesia and altered body perception. So the neuropeptides released by sensitized peptinergic nociceptors cause neurogenic inflammation. Autoantibodies on adrenergic and cholinergic receptors alter the sympathetic nervous system function. There are mainly two types: CRPS type 1, which is called as reflex sympathetic dystrophy following minor injuries, fractures, or surgery. CRPS type 2 is causalgia, mainly after injury to a major peripheral nerve. CRPS 1 contributes to around 63% of the total CRPS, and which includes about 11% of upper limb injuries. So it is divided in three stages: acute stage, which is seen immediately after the injury and lasts for about 6 to 8 weeks. In this stage, it is most likely to be reversed and cured if properly treated. It presents as a red, warm, swollen hand. It may be a dry, inflamed, and later on changed to blue, cold, and sweaty hand. The pain is distributed near the site of injury. It is not compatible with a single peripheral nerve, trunk, or root lesion. It is characterized by hyperesthesia and burning pain. There is associated sympathetic dysfunction in the form of vasomotor disturbances of variable intensity, producing altered color and skin temperature, and altered pseudomotor function in the form of increased sweating, altered motor function in the form of weakness, muscle cramps, stiffness, spasm. The X-rays look normal in this stage, and bone scan may demonstrate increased uptake, but it is not having any prognostic value. Stage 2 is the dystrophic stage within months of injury and can last several months after the injury. The skin becomes cool, moist, tiny, tight, shiny. There is swelling, which may be soft to hard. There are hair and nail changes. Pain is constant. It is a throbbing type, burning type, and exaggerated by stimuli. There is associated psychological distress due to more severe and diffuse pain, which may be throughout the limb. Sympathetic changes, there is vasoconstriction leading to cyanosis, edema is there. Again, altered pseudomotor changes in the form of increased sweating or decreased sweating, and osteoporosis, which is evident on X-rays. There is associated muscle wasting, tremors, and stiffness of joints. So stage 3 is atrophic stage. It lasts for years, from months to years. Pain is still constant. Sometimes it is variable in degrees depending upon the patient. It may be less at rest, worse with passive motion, and sometimes intractable and may involve entire limb. And in this stage, sympathetic blocks may not work, and changes are somehow irreversible. In this stage, CRPS features can extend beyond the region, original region, and skin may look atrophic, waxy, very thin, or associated with ulcers. Again, there are sympathetic changes, vasoconstriction, cold extremity, intermittently cyanotic or mottled appearance, and non-functional limb associated with contractures, dystonia, muscle wasting, tremors, and X-ray may show classical diffuse patchy osteoporosis that is termed as Sudeck's atrophy. So there are Budapest diagnostic criteria to diagnose CRPS. Patients should have a continuing pain disproportionate to the inciting event, and symptoms, at least one symptom should be positive of the 3 of the following categories, that is hyperesthesia, allodynia, temperature, sweating changes, decreased range of motion, and so on. And at least one sign should be positive of the following 2 categories, and no other diagnosis should be there. So to rule out, we have to rule out vascular diseases, cellulitis, infection, inflammation, neuropathic pain syndrome, or myofascial pain. And for that, there is no specific laboratory test available. But to rule out infection, we can do WBC, CRP, ESR. To rule out rheumatic disease, we can do anti-nuclear antibody. Similarly, to rule out peripheral vascular disease, we can do ultrasound, Doppler. And to rule out, to know the fracture, non-union, we can take X-ray, bone scan, or MRI to know the soft tissue status, to rule out tenosynovitis, osteomyelitis, etc. We can perform nerve conduction velocities to exclude peripheral neuropathic disease or compression neuropathies, and imaging may only demonstrate osteoporosis in affected limb. So the medical management mainly is oriented a multidisciplinary approach, which includes pharmacotherapy, mainly to relieve pain of the patient, painkillers which may be NSAIDs or tramadol at times, to improve sleep, antidepressants like nortriptyline can be given, pre-GABA, anticonvulsant like pre-GABA can be given, temporary courses of corticosteroids can be given to reduce inflammation and to reduce bone resorption. Bisphosphonates, calcitonin can be given, and vitamin supplements like vitamin C, B12 have some role, and symptomatic treatment of muscle cramp can be given in the form of baclofen or clonidine patches, etc. So mainly the acute stage is concerned about physiotherapy and vocational therapy, which includes stretching, active exercises, edema control, continuous passive motion. Especially mirror visual feedback is helpful in improving the function of the hand. Patient should have proper sleep. Patient should be assured by a psychotherapist and motivated for doing physiotherapy. And but the physiotherapy should be given carefully. It should be gentle and below pain threshold.
Madam, 1 minute is remaining, madam. Yeah.
Must not exacerbate the pain. And those who do not respond to drugs and physiotherapy should be given sympathetic blocks in the form of stellate ganglion block, which break the vicious cycle of pain and permit more vigorous physical activity. And there is some role of neurolytic blocks, spinal cord stimulation or peripheral nerve stimulation to relieve pain. So it is important to treat the cause, especially when there is associated neural injury. We should identify the cause, whether it is nerve irritation or nerve injury iatrogenic, whether it may be related to a impinging plate, implant, or K-wire. In such cases, we should perform extensile neurolysis, excise any synovitis adhesion scar if present, mobilize the nerve. If there is any neuromine continuity, it should be excised and the nerve should be repaired or grafted, and it should be covered with fat or fascia so that neural environment is modified and it is away from the scar tissue. And in cases of CRPS type 1, after a waiting period of about 3 to 4 months, once the acute phase is over and there is plateau of symptoms, and the patient has gone into quiescent stage a little bit, then the corrective osteotomy for gross deformities or contacture releases for MP joints and PIP joints can be performed. So it is important to restore the full function of the affected area of the CRPS, and the treatment should be immediate after diagnosis, and it should involve multidisciplinary approach with the combination of pharmacotherapy, psychotherapy, physiotherapy, and intervention of a pain therapist, which is usually the anesthetist and the treating surgeon. And it is important to treat the cause, whether it is a neural injury or whether it is related to trauma, and try to improve the patient pain. Thank you very much.
Thank you.